All right. Welcome, everyone. We have an absolute record turnout tonight. I'm really excited. Thank you for joining Residency Hot Topics. My name is Ben Keaton. I'm the organizer, and I am so thrilled to welcome Dr. Wesley Wang tonight. He is a world-renowned expert on ACL and is our cutting-edge ACL presenter today. Really excited for your content, Wesley, and the floor is yours, sir.
I appreciate you having me. I appreciate all you guys for joining. Hopefully it's informative today, and I look forward to engaging with you guys at the end for some Q&A. So I was talking to Ben of just obviously different topics, and me being the big ACL guy, I wanted to just share a little bit of my thoughts. I also want to share a little bit about my journey to get to where I am, and hopefully inspire some of you guys who may be looking to go into this sports/cash-based world. So just a little bit of background is that I went to the University of Maryland, College Park, and graduated actually with an economics degree. Didn't like that field, so I ended up changing careers and decided on physical therapy. Graduated from Franklin Pierce University in 2015. Crazy enough, I'm hitting my 10-year mark this year. I worked 2 years at a traditional physician-owned outpatient facility. Was only at my first one for about 6 months, and then transitioned to a different one for about a year and a half. Knew I always wanted more, but just didn't really know how to get there. And thankfully, in October of 2017, Teddy, who some of you guys may follow, known as Strength Coach Therapy on Instagram, decided to hire me, and I've been there for 7 years now, which is crazy. So yeah, again, just Maryland. I ended up working at Accenture, which is a pretty big consulting firm. I tore my ACL right before that, so that's really how I got exposed to the field. Going through my own rehab process of getting back to playing basketball again was a really fun process. Like I was going to rehab at like 7:30 in the morning, and then taking my long metro ride to work, and just had a lot of time to think essentially of what I wanted to do for the rest of my life. Finally made the leap, but coming from a business background, I had zero science classes, so I'd go back to MC, which is a community college here. Did that for 2 years. So I was taking classes with people who were 4 or 5 years younger than me, which was humbling because they were smarter than I was. But doing all the biology, chemistry, which I'm sure all you guys remember, and then went to Franklin Pierce, and eventually working as a physical therapist. Again, my first 2 years, standard outpatient treatments were dictated by the surgeons or the orthopedists that owned the facilities. On average, saw about 12 to 15 patients per day, 30-minute treatments. There was like recommended numbers that you had to hit for units billed and all that kind of stuff. The facility, frankly, wasn't designed for athletes. It looked sort of like this. This is not the exact picture, but sort of like this, a bunch of tables. I rarely saw any athletes. I'll be lucky to have maybe one or two athletes. And frankly, one of the bottom bullet point was like I had really no one to really teach me. It was just see your patients and then go home, and that was sort of rinse and repeat every single day. So I knew it's not really where I want to go, and frankly, I didn't really grow as a clinician my first couple years. Um, and I was asking myself, why did I want change? I found myself growing very complacent at my last job. All I ever looked at was how many units I was billing and how many people I was seeing, because that equated to how large my paychecks were or how big of a bonus I was going to get every quarter. Again, I wasn't growing as a clinician. I was just caught up in meeting the numbers, and I was also restricted by the physicians. They had their own protocols and certain things I just didn't necessarily agree with. And it was hard to combat them because ultimately they were my bosses. One specific example was that I had a eighth grade girl who had a meniscectomy. Was never even given the chance to do any rehab, but the surgeon decided to cut into her knee, and that's a very permanent thing that can't be reversed. And I had to sort of like accept it, and I couldn't say anything negative about it because again, they were my boss. That was one of the final straws for me of starting to think about next steps. I would say that was also time when social media was becoming bigger. People like Teddy and prehab guys, they were the sort of the first pioneers of starting PT Instagrams and stuff. And that's ultimately how I got really exposed to what sports PT really looked like. And again, lastly, ultimately, I just didn't get to treat the way that I felt was best for my patients. And again, I couldn't say anything, so I had to sort of bite my tongue. And how did I end up a healthy baller? This is a quote that I found. If somebody offers you an amazing opportunity, but you are not sure if you can do it, say yes, then learn how to do it later. I felt this perfectly described me and my situation, because when Teddy said he was going to hire me, I was sort of like, why is he even hiring me? I remember he told me I was one of three finalists. One dropped out, and another person, it is like, I guess it just wasn't the right time for this person, because I think he had a young kid. So I don't know if I was just plan C, but thankfully I got the job. And I've worked every day since then to prove that Teddy made the right decision. And hopefully, if you asked him if you ever met him, that he would say that he made the right decision. But yeah, a lot of learning has occurred over the past 7 years, and it's been challenging from both the clinician side, but also as a business owner, and also even mentoring the clinicians under us, the PTs that we have hired after me. It's sort of just been a really, really fun and challenging environment for me at Healthy Baller. Our PT model, we're really big on bridging the gap between rehab and performance. We do get some people who come see us directly or like immediately post-op, but we do see, I would say, a good fair share of our people go the traditional route, and then they'll come see us after that because their insurance runs out or they feel like they're ready for the next steps, whatever it may be. That's sort of where we really come into play. My primary caseload is mostly high school and college level athletes. I'll see the occasional pro athletes and then also see some active adults as well. My three sort of pillars of rehab is focused on movement, strengthening, and patient education. I really, really love building relationships with my patients. I think because of ACLs, like I see them for so long, and it's really cool. Like some of my kids that I work with from 6 years ago, some of them are getting engaged now, and I haven't seen them in a handful of years, but they'll still text me or anything like that. Like it's been great to still have these relationships for so long. And I think another big thing that's unique about our facility is that I might work with a girl freshman in high school or a boy freshman in high school and get them back, and maybe they want to play college sports, and they'll keep training with us for the next 6 7 years. So it's again a very, very unique environment where we have the ability to do that, and we see these athletes for quite a long time. Again, we're cash based, and we see every single patient for an hour, so it's very, very different than where I used to work. Now onto, I guess, the big topic of ACL rehab. This is the statistic that I chose to start with, but this is sort of my big reason why I've really catered my social media to educating people about ACL tears. But 25 to 30% of ACL patients suffer a second ACL tear. And in my opinion, people don't ask the right questions. A lot of people just sort of accept that this is the reality when the only reason why this is the reality is because of improper treatments. And again, that's sort of what I really push on my Instagram of just showing people of like, this is what I believe high level ACL rehab really looks like. And I think that unfortunately it's not the industry norm. And that's sort of I would say plays a big role into why ACL tears are so high. And just to backtrack a little bit, when my first year at Healthy Baller, I really tried to network with people and just build relationships and basically just try to build a name for myself. And I went back to the doctors that I used to work for that I had a good relationship with, or at least I thought I did. And I had a presentation and I showed him statistics, and I was just like, hey, like when you clearing people was one of my big things. And then he was like, I clear my ACLs at 6 months. And I showed him all the research about why 9 months and over is ideal. And to this day, he has sent me zero people. And it just shows that like if people don't care to read the research and think that what they know is best, they're just going to keep this cycle over and over again. And I even asked him what his retail rates are, and I showed him this statistic, and he was like, "Yeah, that sounds about right." Almost like it didn't even matter to him. Again, this is sort of, and I would assume that there are many other doctors out there like that, or many other PTs out there who don't care to even learn about ACL rehab, and that's sort of the big motivating factor for me about why I keep going. ACL rehab, in my opinion, is extremely complex. I think it's probably the most complex injury in the outpatient world. But unfortunately, our field sort of treats it as if it's some generic injury. You could have maybe a very basic outpatient rotation, an inpatient, a neuro, whatever it is, and then you decide you want to go work outpatient, and you might get an ACL your first month there, and you have never really actually treated an ACL. And that's the reality of just how our field really views ACLs. And the question I always ask is, who's the one who suffers? It's the patient that suffers. And that's, again, part of the problem about why these re-tear rates are so high. In my opinion, not every PT should be able to treat ACLs or is qualified to treat ACLs because there comes with a lot of education, a lot of continued learning, which some PTs don't really care to do. I think that another big thing is don't blindly follow protocols. A lot of protocols are written by surgeons, and I'm going to show you one in a little bit. When my question I like to ask or challenge people is how many surgeons have actually ever rehabbed ACLs? And the answer is zero. I always tell my patients that like the surgeon really shouldn't be giving too much rehab advice, just like I shouldn't be giving any surgical advice. We're the ones in the trenches. We're the ones there with them 2 to 3 times a week, hours on end, weeks on end, months on end. When in reality, the surgeon sees them at 2 weeks, 6 weeks, 12 weeks, 6 months, and that's 3 6 months, and that's about it. And every appointment for them is about 10 to 15 minutes. So again, I always ask, like, the last bullet point is, why are surgeons the ones clearing when in reality it should be us if you have the ability to do so. And that comes again with proper education. The fourth point about improper facilities for mid to late stage rehab, which I showed, a picture of a typical outpatient facility. That facility just doesn't have the ability to do that. That's not a knock against them. It's just a fact, right? They don't have any open space. They can't get up to full speed. They can't cut. They can't do reactive movements. Like, how does that prepare them for the demands of playing sports again? And in those settings, a lot of times, like, 5 6 months, your insurance might run out, or you're tired of paying whatever your $100 copay because your insurance ran out, and that's their cash rate. You're tired of paying that because you're doing the same stuff over again, and then you just sort of self discharge, and you're doing stuff by yourself, and you're like, okay, yeah, I feel pretty good. Go back to playing soccer, basketball, lacrosse, and then boom, you tear your ACL because you were never actually tested. Which leads me to the fifth point about improper return to sport testing, which is massive. That's ultimately what safely dictates when an athlete is ready or not ready to play sports again. And that's what I tell every single patient that walks through the door, is that, like, it's not me guessing, it is you passing all of our tests. And that should prove to all of us, including your coaches, parents, etc., that you are ready to start returning back to sports again. And that's what I feel like is a pretty comprehensive rehab process. And we'll go into more detail in a second. And in my opinion, what needs to change? Better education on ACL rehab and research. That's why I've started. I have my own ACL mastermind group where I teach people who really want to learn. Also, I have an in-person course which sort of takes that to another level. And even within my course, I have 7 labs and 3 demonstrations where people, like, we're getting up and we're moving, we're trying things, because that's, in my opinion, how you learn the best. Better protocols where the surgeons are actually talking with therapists who are actually treating, of how to write an actual protocol. Better focus on the foundation, which is like range of motion, getting the swelling down, gait training, all the basics, understanding of how to progress patients, and we'll go into this more in details in a second. Exercise progression, I think, is really missed a lot of times in PT schools. At least for me, like, our exercise was sort of like, if one exercise is too easy at 10 pounds, just go up to 15 pounds. When in reality, there's a lot of different things that you can manipulate to make things harder without always necessarily going up in weight. Also decreasing reps. Like, there's just so many things that you can change that can offer a better rehab program. I think another big point is referring out when the patient is no longer progressing. At my facility, I used to refer. That's ultimately how Teddy and I met. Is that I referred someone to him, because again, the heaviest dumbbell we had at our facility was 10 pounds. This girl was about 3 4 months post-op, and I was sort of running out of things to do, and I felt like the right decision was to transition her to somewhere like Teddy. Return to sport testing, which I'll show you in detail about how our process is. And again, in my opinion, physical therapists should be the one given the clearance, and recognizing that no two individuals ever recover the same, which is why a generic protocol is really hard to follow, because most of the time they're week or time based, like the one you see on the screen right now. And the one thing I really wanted to point out, it may be hard to see on your screens, but the second to last point, the one that's in all white, it says that week 16 to 20 is a full return to sport per Dr. McCarty. Again, it's the doctor that's doing the clearing. It's just so wrong. There's nothing right about this, and it's just all these. It's such a generic protocol. First of all, the time is absurdly wrong. Let alone the fact that the doctor, who barely sees you, is the one doing clearing. And again, if you look at the bottom, it's his review of goals. It says full range of motion and full quad/hamstring strength, 5 out of 5 NMT, which NMT is sort of a joke. So subjective. The size of the patient, the size of the therapist matters. And again, it's a subjective scale when it should be objective testing that ultimately clears patients. So real quickly, and it was hard just based on time, but I wanted to summarize sort of the 4 main pillars of what I believe ACL rehab should look like. And I'm going to summarize my entire course into 5 minutes or so, 5 to 10 minutes. But essentially setting the foundation. And what I mean by that is full range of motion, getting your quad muscle tone up, and also decreasing swelling and normalizing gait. Those are sort of the 3 to 4 main pillars that we really, really want to focus on. And for me, I don't really jump into the next phase, which is slowly starting to actually progress strength training. until they really show me that they have full range of motion. A really heavy emphasis on full extension. I would say a lot of times I've heard one too many times where people are told that their extension is good enough because they have zero, when in reality we know that hyperextension is normal, especially in females. A lot of times females that have 5-6 degrees of hyperextension, which is totally normal. I want them to be able to access that full extension on the non-ACL side, or sorry, on the ACL side. So I tell them that for me, you should be able to walk in the walk into to the session, hop on the table, no warm up, squeeze your quads, boom, you should be able to access your full extension immediately without any warm up. That's when I feel like, okay, cool. Now your extension's great. Now let's really focus on starting to do some strength training. Gradually build strength and tolerance to essentially like your knee and quad being loaded. That's a very, again, I wrote a small sentence there about the complexity about what ACL rehab really looks like. That is probably the hardest part, is slowly exposing the athlete to different loads, different tolerances, especially your patella grasp, which is they're really sensitive, which I in the front of the knee. It's our job to gradually load them to tolerance over time. And that's basically summarizes what the rehab process looks like from day one post-op all the way till 9, 10, 11 months post-op. Everything is just gradually building until you can pass certain tests. And then cool, now you're cleared to start running again. Now you're cleared to start cutting again. Now you're cleared to start going non-contact practices. Everything starts with what you're doing in the weight room in that early phase. Because if stuff is hard early on, it just pushes the timeline back. And I never really give patients timelines. I just tell them like, hey, we're just trying to focus on your progress, which is hard for young people to hear sometimes. But I tell them that every journey is your own, and I want to make sure that as long as you're progressing, that's all you should really care about. If it takes you 9-10 months, that's great. If it takes you 11-12 months, that's fine. I'd rather make it so it takes a little bit longer, but I never have to see you in my office again. And I think for me, because I torn both my ACLs, it sort of carries a little bit more weight because they know that I share about my journey, and I was not tested going back, and I was clear to play in a basketball tournament 7 months post-op. So all these things that I've learned from my own journeys, I tell them. And like ultimately I tell them that ACL rehab sucks. Like it's not fun tearing your ACL. It's not fun going through rehab twice a week, 3 times a week, and missing your practices and games and recruiting season, all that kind of stuff. Like, let's make sure we do this the right way the first time. The third bullet point is addressing details, including loading and visual compensations, and also neuroplasticity. This is one I'm really, really big on. Every single ACL patient wants to take the path of least resistance when it comes to honestly anything, especially when you talk about like quad tasks. They really, really want to avoid loading that quad and loading that knee, especially things like a forward step down. That's really hard for patients to understand or even perform. And then going through like more bounding or single leg landing, that's really, really hard. And they want to just cheat it to any capacity that they possibly can. So it's our job, again, starting from that early phase of loading in that 5-6 week time frame, you should already be starting to clean things up so that when they get to 4 months or so, like they understand all the compensation that they had, and that hopefully they're eliminated or significantly reduced by then, so you can just focus on loading at that point in time. And then the rest of the way is just heavy loading until you get to that late phase when they're passing all the tests, and that's ultimately what it's all about. And my last bullet point is test, don't guess. And that's what an MMT is. You're guessing whether or not they're ready to go. And if you say they're cleared at 6 months, like, how do you know that? You can never guarantee that someone is cleared. And if people are saying that, that ultimately tells me that you don't really understand the nuances of ACL rehab. And again, these protocols that I just shared in that last slide, that's what they're saying, right? They're saying that no matter what, at 4 to 5 months or whatever it is, you're clear to go back. Like, how do you know that? And my imperfect analogy is that when you turn 16, they don't just give you a license and allow you to start driving. You have to pass a test to allow you to drive. And sometimes when I say that to people, it sort of clicks in their head like, yeah, that sort of makes a little bit of sense. So I tell people that you have to earn the right to get back on the field, get back on the court again. And that's ultimately the best thing that we can do, is to try to eliminate or reduce as much risk as possible when you go back to playing sports again, so you don't become a part of that 25 to 30%. Here are some compensations that you'll see in these clips.
Go for it.
Here is a lateral step down. That is her non-side, and that is her ACL side on the right. Number one, you're seeing that she's going a little bit slower, obviously, and you'll see that she has a left hip dip at the bottom. And on top of that, it's hard to see here, but she has a trunk lean on her right side. If you watch them both side by side, you can see that one she's going slower, very smooth on the left, and very slow on the right. And she's also leaning forward with that hip drop. So that's one example of a compensation that I would definitely want to address.
Go for it.
Here's another one. There's a prone hamstring curl. This is one probably not seen too often.
This is so depressing.
Sorry. What you'll see is in the left clip, that is her ACL side, and then her non-ACL side's on the right. You'll see which one goes much further, right? On her non-ACL side, she's able to pretty much get her foot to her butt, right, with no real issues, very fluid. And again, showing you on this side, she stops at 9 degrees. That is a very common issue with hamstring grafts, is that they really, really struggle with end range knee flexion strength. So again, it's our job to be able to understand this and then address that in the rehab process. Here's another one of the same woman. Another competition you see is that the external rotation of her foot. The left one is her ACL side. The right one is her non-ACL side. You'll see that her right side's in neutral, while her ACL side is externally rotated the entire time. And the primary reason why is that typically they're taking the semitendinosus, which is on the inside, which you guys know, which just causes that foot to externally rotate, again, just due to a lack of strength. And that body's just trying to figure out any way to basically perform the motion or perform the exercise. Here's a step off. So we talk about loading compensations where she's just doing a very simple step off. I do these before they jog, just seeing if they're comfortable loading that knee with a positive shin angle. So can you get their knees over their toes? Do they excessively trunk lean when they perform a relatively simple motion? Okay, that's our ACL, non-ACL side. There's a step off on the ACL side. Boom. And what you see, knee doesn't really want to track over her toes. And on top of that, look at that excessive trunk lean, and she also falls. So these are, again, examples of details that really, really go a long way. And unless you have a lot of experience seeing this and looking at this, like, it just sort of becomes unaddressed over time. And the longer it becomes unaddressed, the more it becomes their norm, essentially. And here's an example of I talked about visual tracking or visual compensations. This is how I help address it. This girl is doing a reactive movement exercise. Basically anything goes, right? I didn't instruct her on how to go get the ball. I was like, just go get the ball. So two things that you'll notice is that one, she has to track the ball. She has to go get each of the two balls. On top of that, if you guys didn't see, behind me, there's an iPad, and I'll turn up the volume. The iPad flashes different colors. So not only is she tracking the ball, she also has to turn her head to look at the iPad in between tosses and yell out what color she sees. So hopefully you can hear this.
Blue, green, orange, orange, purple.
Right. And again, very taxing. It's very hard, but we're ultimately trying to, again, prepare her for the demands of sports. And I think visual compensations is honestly pretty massive. Every single ACL patient, if you guys are treating them, I really encourage you to look at these things. Just watch them do, honestly, even strength training, like a step up or anything like that. Every single ACL patient will, unless you instruct them otherwise, wants to stare at the ground. And it's just one of those things that just has to be addressed. I always explain to them, like, you don't play basketball, soccer, lacrosse, whatever it is, staring at the ground. That's not how sports works. You have to be able to look up. You have to trust your knee. And again, there's a lot of research out there about how much visual compensation plays with neuroplasticity and just how much all of that is affected and your brain is affected. And that starts with, again, working on some of the stuff in the rehab process so that when they get back to playing sports again, all these movements feel very natural because they've done it over and over and over again without having to look at the ground. And I feel like that's a comprehensive look as to how the movement part of rehab really works. But even with strength training, I tell them, if you're doing a step down, a step up, whatever it may be, like, keep your eyes up. If you're doing a bound, like the woman I showed you doing the step off, like, keep your eyes up. Always, always, always keep your eyes up. So for me, that starts, again, that 4, 5, 6 week time frame, like where we're starting to strength train a little bit. Always start addressing these things early and often. This is an example of our isometric testing station. Teddy literally built this, which is awesome. It's something that I really, really wanted. And him being super handy, he was able to build this contraption. But you'll see the device hanging from my ankle. For us, we use Kinvent. It's a nice system because you can make a profile and you can track the progress over time. But this is a 90-degree knee extension test. You see, we strap him down with the seatbelt and just have him push into that thing isometrically as hard as I can for 5 seconds, 3 reps compared to the non-ACL side. And that's how you can at least get some strength measurements for basically assessing their quad strength. We do 90 and 6 degrees, which is the picture on the right. 60 degrees, just so you have 6 degrees is typically where peak quad contraction happens. So you want to try and be testing at different angles. This is an example of what data looks like. You probably won't be able to see the small numbers, but if you look at the top right, you'll see the big numbers. On one hand, the one on the left, that was done earlier. So you can see on the left, the ACL side is 38.8 kilograms compared to the right, which is 50.6, which is a 23% symmetry difference, meaning that they are at, was that 77%? If I did my math right, yeah, 77% strength compared to the other side. And then you look a little bit later, we obviously kept strength training, and you can see at the left side jump from 38.8 to 54.7 kilograms, which is awesome. And then the right side even jumped from 50 to 62. And even more so, their percentage dropped from 23% difference to only a 12% difference. For me, this is like a beautiful depiction about what strength really looks like. Because yes, obviously the left side jumped up a lot, but the right side also is starting to return back to what their normal baseline is, because you should still be strength training the non-ACL side as well. It's a matter within your programming to find the balance between how much you should still be loading the ACL side more, but still not neglecting that other side, because you don't want them to return back at for this example, 50.6, when in reality they should be closer to that low 60 mark on this specific test. So this is a great example of sort of how we test and how we track progress. And this is, again, it's so easy to show. I can take a screenshot, send this over to the parents, the doctor, whatever it may be. It just helps you create more credibility in regarding to ACL rehab specifically. We also do isometric hamstring testing. This is 2 variations. One's prone, one's seated. Exact same type of measures that you would see in regards to the metrics on the last screen. This right here is my pride and joy when it comes to testing. This is called the leg X. It allows us to test our quad strength concentrically, which I feel like is extremely missed in the rehab world, unless you have access to a Biodex, which 95% people do not have access to. This is my version B of it. And I've had athletes who have had the ability to test Biodex at school, and they'll come and do my test, and they'll tell me that it feels pretty much the same, which for me is awesome. So this is the ultimate test. If you made me pick a single test that we have, I would pick this one. Not that we would ever do a single test, but this is by far the hardest test to pass, and always consistently across the board, the last one that people will pass. And again, for me, I tell them that once you pass this, that's sort of like when you know, okay, now we're really moving, and now we're really ready to go back to playing sports again. This is the data. The orange line is the concentric line, which is the one that we really emphasize. So you could tell in this example, her ACL side is at 169, and then her non-ACL side is at 185. And again, you just take 169, and this takes the average. The 169 is the average of the 5, 185 the average of the 5, and you just do 169 divided by 185, and there's your math. This also tells you things, if you see at the bottom, average power, concentric peak power, and then your eccentric peak power as well. And then a little bit more data. It also tells you things like average force. It also tells you your speed, your peak speed. So it really just allows you to track as much as you would like when it comes to concentric quad strength. We also do force plate testing. It allows us to test like a jump and see if they're landing unevenly. When they take off, are they pushing off unevenly? We also do single leg jumping, which allows us to basically gauge. One of the big ones is essentially vertical hop tests. There's the traditional hop test, which I'm sure a lot of you are aware of, and there's a lot of research that says that that is more indicative of more glute strength when it comes to propelling yourself horizontally. The landing places a lot of demand on the quads, but that's not what the test is measuring. The test is measuring your ability to go from point A to point B, and you track the distance and you compare the 2 sides. But vertically, it places a lot more emphasis on the quads, so it allows us to really tease out if there's any differences between the 2 sides. Data-wise, the second line is the jump height. This specific example was 0.09 meters on the ACL side, and then 0.13 on the non-ACL side. So that would not be a pass. I think that's roughly like 80%, something like that. So that would not be a pass for us in this situation. There's a lot more data in the force plates. This spits out a ton of data. Some of it's pretty overwhelming. But the jump height is one of the big ones that we really look at. So I tried to summarize everything as quickly as I could. But any questions when it comes to honestly any of the stuff that I talked about today?
Excellent job. Thank you, Teddy. I'm sorry. Thank you, Wesley. The first question came from Laura. She asked what app you were using for the color changes on the iPad.
That is actually a YouTube color changing. Like I literally just look up like color changing on YouTube. But one app that I use pretty frequently is called Switched On. It allows you to customize certain things. You could customize the color. So, for example, like sometimes I use it for single leg balance. If I only have like a red, orange, and green cone, I can choose red, orange, and green on the app and set that like somewhere and have the athlete turn their head. So the Switch On is a really nice app because you can also use numbers, so you can make them do math and do single leg balance. There's a lot of different things that you can do on that. So yeah, I use Switch On really frequently.
Excellent. And the next question is, what are your favorite metrics for counter movement jump and single leg jump?
Um, we definitely use the force plates for those. There's different variations. You can just do a simple like single leg jump. I know that we've also done like stepping off like a 12-inch box onto the force plate, doing a counter movement jump vertically and landing. Those are probably the two most common ones that we utilize.
And Kurt asks, what is your typical plan of care structure and cash-based for ACL rehab?
Um, I would say I guess my follow-up question would be depending on what phase. I talked about the various phases, but if you're talking about like the late stages, we typically would start with like 15 to 20 minutes of some sort of movement, and that's when I'll ask the patient about what they're most fearful of, whether it's decelerations, reactive movements, contact, whatever it may be. That's the time that would really work on that. And then from there, the rest of the time, the rest of the 45 minutes, and sometimes honestly, patients will hang around for like an hour and 15, hour and 30. But just the one-on-one with me is the whole hour. And by that time, they should be really proficient in the weight room. It's just a matter of like me writing out the program about what to do. So from there, the rest of the 45 to an hour or so is strength training, plyometrics, force development. That's sort of what that last 45 minutes for. For me, strength training should always be the priority. I don't care if you're 6 weeks post-op or you're 9 months post-op. Strength training should always be the priority, because that's ultimately what's going to decide when an athlete is safe or not safe to play their sports again. Yes, and even for what I found is that like the stronger athletes are, typically psychologically, it sort of comes with that. So I think that again, strength is sort of the number one priority all the way through.
And Patrick asks a follow-up question on the strength point. Are you testing hamstring isometric strength on all ACL repairs or only hamstring grafts?
All of them, definitely all of them. Yeah, hamstring graft, I would say we have to tease out a little bit more. Hamstring testing, I would say for us, like typically we'll test at 60 and 90 on every patient. But for hamstring grafts, I might push that a little bit more to like 100 or 105 or so because of that end range knee flexion strength that patients are lacking that I talked about. Again, it's not really something that you see too often. I haven't seen a hamstring graft in actually quite some time. That woman was probably a year and a half ago. But it's sort of like when you do see them, you start seeing all the compensations and what they really struggle with. So yeah, I think with hamstring grafts, you might want to tease out a little bit more at deeper knee flexion angles, but definitely testing hamstring strength on everybody.
And do you use any agility performance-based testing like 505s, repeat sprint tests, etc.?
Great question. Me personally, no, because our strength coaches do that. The majority of our athletes, particularly our high-level athletes, will transition to our strength coaches roughly 7, 8, 9 months, depending on, again, I hate time frame, but you know what I mean, in that late phase. So the strength coaches will do a 505 and a 5-10-5, and then they'll use that to track like how well they're turning and all that kind of stuff. I sort of allowed them to do that. They have the whole timing gates and all that kind of stuff set up, so it's really, really proficient the way they do that.
Jeff asks, what is your approach or philosophy regarding resisted terminal knee extension in early phases of rehab? Is that contraindicated or no?
Resisted as in like a knee extension machine or as in like an over pressure for range of motion? It would be the
It looks like from a knee extension machine, like open chain knee extension.
yeah. That's a great question. I figured that'll be asked today. Um, I I think throughout my career, especially for the last 7 years, really focusing on ACLs, I've sort of like played with both sides of it, like being on the more aggressive side and starting full range of motion whenever they can tolerate it, onto like the flip side of like being very slow, doing ISOs first, and then going to partial range for a while and not going to full range until 3 months. I've literally been on both sides of the spectrum. I think for me right now, I've sort of fallen in the middle. I think that there are therapists out there that you see might post them at 4 weeks and they're already doing a full range knee extension, which is perfectly fine. If you don't have any pain with it, I'm perfectly fine with it. So I think for me, I've sort of again fallen somewhere in the middle where I'll start with ISOs first, and then gradually over time I might go active with no weight and then start adding an ankle weight, because that really doesn't place a lot of stress, especially in that like early range of motion from like 90 to 60. That ankle weight really isn't doing a whole lot. Um, but yeah, I frankly don't have any issues with people who are willing to be a little more aggressive. I think for me, it's always comes down to patient tolerance. If the patient can tolerate it and there's no pain, particularly with your patella tendon grafts, by all means, I'm perfectly fine with it. The research supports that it's safe, so I'm fine with it.
And Cynthia Jacobson asks, what is your LSI percentage, 70 or 90% for bilateral testing strength for return to sport?
I shoot for 90 on almost pretty much every single test. I know that I believe with the ACL RSI, the psychological test that I give, I think research wants like 80. But if I can get sort of everything to above 90, and to be honest, I want them to get to 95. And I tell them that the reason why I honestly haven't been able to find this article, but one article that really stuck out was the fact that basically logically it makes sense. If you get cleared, let's say, at least for us, soccer is a fall sport. If you get cleared right, let's say August, and you hop right into a season, we know that for the most part, people get weaker during the season. You lift less, you have less time, etc., all this kind of stuff because of practices. So that 90 might drop into quote unquote the danger zone, and you might drop to 88 or 87%. And now you are at risk. And there's what the research, at least some articles will say, is that for every percentage point you're under 90, you're 3% more likely. So if you're at 87, you're 9% more likely to get injured than someone who's at 90. So if I can get you to 95 and you fall to 92, you're still considered in that safe zone. So I always tell them that if once you're at 90, you have my clearance to play, but that means that you have less room for error than someone at 95, and you need to stay on top of what I call like ACL maintenance lifting, which means that you're not like lifting super, super heavy, particularly during the season, which is hard to, but you should be lifting moderate weight. And there's videos of like NBA players who are lifting immediately after games. And it's a matter of like just honing in on 20 minutes of like good lifting, and then you're done for the day. Try and get a rest day if you can. Like, I think for me, doing little things like that really goes a long way to staying as healthy as possible.
Next question. Do you have any eccentric quad testing or single leg hop, triple hop, etc. off the force plates? Why or why not?
Triple hop, not off the force plates per se. Typically we do the ones that I said, like a single leg vertical jump or a step off vertical jump. But we do the traditional hop test. To be honest, I never measure it. I tell them that like I want you to be even for this one, not even 90%, because I think that if you're at 90, you're definitely not ready to play. Just because again, what I explained about like based on what the breakdown was of a research article has told you that like basically to get from point A to point B in a horizontal plane is essentially 1/3 between your calf, your quad, and your glutes. So it really doesn't even tease out the quads as much as people think it does. So if this motion allows you to utilize a bunch of different muscles, then you should be able to get from point A to point B pretty much even. So we place much more emphasis on the vertical jump distance or height, as opposed to a horizontal, the more traditional hop test that people do. If you made me pick like priority wise, the traditional hop test is probably the lowest on my priority. For me, it's more so a gauge of like psychologically, like, are they willing to go as far as they can equal to the other side? And the other big thing is like the hop test, like I think you can do as many trials as you want. So it's like if you take 15 trials on your ACL side, but you're technically even or within 90%, but your non-ACL side can complete the same task in 4 trials, is that really, a successful test? And in my opinion, it's not. So I don't place a lot of emphasis on the traditional hop tests.
Next question. How much are you holding the patient back from progressing strength or further exercises until their true range of motion goals are hit?
Great question. I want to say it's a little hard to explain. Like if you're missing a ton of range of motion, like I'm holding you back, right? If you're missing 7, 8 degrees of extension, there's really not a big benefit. Like, yes, we're doing quad sets, maybe like really baby short arc quad type of things. Like, yes, we're working on that to work on quad activation, but I wouldn't necessarily call that like actual strength training per se. Because if you're missing that much range of motion, like you're not going to be able to actually work on the quads as much as if they had full or near full range of motion. So like once they're, pretty much there, like 90% of the way there, then we're starting to introduce some of the quad loading tasks. But even then, it's pretty low level. I use our total gym. Like we have a total gym where you can, recline it back to really decrease the patient's body weight. I utilize that with BFR, which is one of my favorite ways of using unilateral quad strength, or incorporating unilateral quad strength. And that's sort of that bridge between like starting to work on strength training. But I won't really load with like weights until they show me that they have pretty consistent range of motion. Again, if they're missing a degree or two of extension and we work on it for 15, 20 minutes before like right at the start of the session and they get there, then I'll start strength training immediately after that.
Do you have a preferred return to running readiness test?
Yeah, there's screens, I based on research wise, they want you to be around 70% strength and I think 2.2 body weight to torque ratio. But I would say some of the other screens that we utilize is sort of like a forward step down test. So for us traditionally about 8 inches, which is a normal step. Can you perform 10 heel touches forward with no pain, pretty smooth getting in and out of it, with no major hip drops? Can you do that? That shows me that your quad strength is at least to a decent point to be able to handle some jogging. We also do like a 10 single leg box squat, to roughly about like a traditional chair. Can do 10 of those. And then we'll also do force absorption. I showed you that video of that woman doing the step off. That's one of the exercises that I like to work on. And I posted on Instagram before of just doing like a very basic, like I call it like an exaggerated step. Can you step forward and actually sink and load your body into that knee? Because if you can't do that, if you can't do like a very basic step and absorb, there's no way you're going to be able to get to jogging. So for me, I want to see all those things worked on and all those things being very fluid and smooth before we even start working on jogging. And then you can start doing like banded high knees, doing some single leg hops on the total gym, like that kind of stuff to work on some force absorption. And then we're starting to work on the jogging after that. So we don't have an altered G or anything like that. I know some of you may have access to that, but yeah, we don't have an altered G, and we've been able to help lots of people get back to running again.
When in your rehab process do you go through your return to sport criteria with the athlete? Early on in care, or do you wait until later to talk through it with them?
I explain that right away. Day one post-op, if they see me for prehab, I want them to understand my expectations early, just so it's not like 6 months post-op. And then, for example, if the surgeon's one of the more crazy ones, they're like clearing people that early. They're like, oh, you never discussed it with me. So I lay my sort of rules right away and tell them my expectations. And I explain my why. I explain that all my decisions are based on extensive ACL research out there. And if they want to see articles, I will send you articles. Because this is my job is to basically make it so that when you go back to sports again, you don't blink an eye. You are ready to go and you're not fearful of a re-tear, and you have the best shot of staying healthy. I'm not batting 100%, but overall my career, I have like 5 re-tears and all of them have been contact injuries. So overall, like we're batting a pretty good percentage. And I think that just comes to a fact that like, it's just preparation over and over and over again and getting really, really strong. I tell every single one of my patients that like, I want you leaving me whenever you graduate from physical therapy, being the strongest version of yourself pre-ACL. And a lot of them are like, is that even possible? And by the end of it, they're like, okay, yeah, it really is possible, because they're dedicating 9+ months of their life into lower body strengthening. I always tell them, I don't care about your body. Like you can work on that on the side, but my job is to make your legs as strong as possible and ultimately as symmetrical as possible. And that's for me what I deem as a successful rehab.
What about those patients who are struggling with quad activation but are afraid of NMES?
Oh yeah, we get those every once in a while. There's two ways you can go about that. You can do a scare tactic and explain to them about if you have good education on AMI. It's something that I've become like super sensitive to of educating. I will educate patients and parents about what AMI is, which is arthrogenic muscle inhibition. Anyone who works with ACL should really start to look at this stuff, because it's honestly like it affects every single ACL patient. But it's a matter of like explaining to them of like, this is the why, like what contributes to AMI. We know the trauma, we know the surgery, we know swelling, we know pain. Those are the four main things that really affect AMI. And I have a patient right now who I explain this to him. Like I have two girls, they're friends, which is maybe the bad part. One did prehab for about 4 or 5 weeks, and we pushed back her surgery because of how much AMI was affecting her. And the second one I think she got her on a Sunday and had surgery on a Friday, so no prehab at all. And I had texted the mom on the Tuesday before, and I was like, "Are you sure you guys don't want to do prehab?" And they're like, "Oh, her quad looks great." I was like, "All right, well, I can't make you come in." And sure enough, this girl is struggling with her quad, and she's 8 weeks out and really still can't get that quad to be fully activated. But to come back to your question, like that's honestly a tactic that I use, is to tell them that like, hey, we have to get your quads going. However, I can tell you in one incident, I had one girl who would grab my hand every single time I tried to turn the stem up, no matter how much I try to lecture her. So I basically was like, well, this is a waste of time. So you just at that point just have to focus on loading. Like it is definitely possible to get an ACL patient and progress them without stim. But it's just like you're just removing a tool that is really, really useful. And if they really hate it and you try for like weeks and nothing changes, then you have to change paths. It's unfortunate, but it's the reality is that some people are too much of a wuss to a certain extent of handling the stim.
And how about BFR? How much are you using BFR? How do you like to use it?
all the time. Well, I'll start using it about 2 weeks post-op. I'll use it with stim, just to drive as much stimulus into that quads as possible. And I'll use it for a while. You know, I wouldn't say, again, I hate timelines, but like maybe roughly as time goes on, you start using it less and less. But like in the early phase, you're pretty much using it with everything, right? I told you, shorter quads, longer quads, partial range knee extension, full range knee extensions on our Kaiser machine, total gyms, step ups, heel touches. We're using it pretty much all the time. And I personally, even just to, I guess, sort of a side thing is like, I don't even do bilateral, like I don't even do a squat anymore until they're closer to about 3 months post-op. Like, you know, for a fact, they have a major strength discrepancy. So what is a squat actually going to be doing? And that's sort of a relatively recent shift that I have, is that I basically stopped doing a squat or trap bar deadlift until they're much later on in the recovery process. It might be 2.5 months post-op before I even think about doing some sort of squat. But yeah, utilize BFR early and often, and then roughly maybe month 4, like 5-ish, we start to wean it off completely, and then we're really just focused on like moderate to heavy load, and then working our way up to heavy load after that.
Mandy asks, how do you wean down PT visits versus strength coach? Do you continue to see them for testing throughout, or do you fully transition over?
Yeah, great question. We're still in charge of the rehab process until they have cleared all our tests. We're thankful enough that our strength coaches that most of our kids work with they're with us. You know, they're in the same facility. I can walk over there, explain to them like, hey, this person's testing at 80% right now. Make sure you stay away from full speed cutting. But other than that, like they can sprint linearly, they can do like 75% speed cutting, all that kind of stuff. Like we're the ones dictating what they should be doing within the movement sessions, and our strength coaches follow that. And then they'll come back to us for testing, whether it's every 3 weeks or so, whatever it may be. But I would say a good chunk of our patients are seeing both of us side by side. So if they're seeing us twice a week, they might cut down to one PT session, and then they'll add the strength coach to replace the second PT session. Every once in a while, we'll get like super eager kids who will go stick with 2 with us because they just want to keep the ball rolling, and then they'll add a strength coach on the 3rd day. So it just depends on what the kid can handle and what the parents financially can handle as well. But I would say most people we still see until they pass all of our tests.
Love it. And I think the value delivery is obviously clear. So what we may think they can or can't do, once you start delivering the value that you're delivering, I think the proposition changes and people are more willing to pay for that for sure.
Absolutely. And I always tell them like it sucks going through it once. Like you really don't want to go through this again. And your parents definitely don't want you to go through this again.
And have you spent a lot of time, Danny asked, educating surgeons and others within your sort of professional sphere about what you're doing and how it's different?
Yeah, we're very, very thankful that we have about 4 surgeons who really, really like what we do and understand that we are niched in the sense that we are seeing mostly high level athletes. And they understand that like we have invested a lot of resource, whether it's on the knowledge side or the testing side, into our process. So we're thankful enough about 3 to 4 surgeons will send us a lot of people. One of them, Dr. Robin West, she's really, really reputable. She was the one who did, if you guys follow football, was the one who operated on Alex Smith when he had that whole knee thing on the field. So she's awesome. And she like loves what we do. Like her daughter trains with us. Like it's been great having that relationship. And she trusts us to like immense levels. Like whenever people are like, when can I get clear? She's like, go ask Wesley or go ask whoever it is. Like, I think that's awesome that she really trusts us from that viewpoint. But on the flip side, I talked about how I networked with a surgeon that I used to work for, and he frankly doesn't care what we do. He'll just keep them at his facility because ultimately that's dollars, that's money in his pocket, right? For every person that doesn't go to his facility, that's just less money in their pocket. And at the end of the day, like it's still a money business. It's still money. So yeah, unfortunately we get surgeons from both sides of it. But again, we're thankful enough to have about 4 surgeons that really, really like what we do. That'll send us people. And it's been those relationships are the one we really cherish, because I'll text the doctors like, hey, Johnny is doing great, or Johnny's struggling with X, Y, and Z. I want you to take a look at that. It's so awesome to just be able to text these doctors when we literally have direct access to them, and they really like it too, as opposed to like, again, my last job, I worked directly under them. They were 1 floor up and I didn't even know how to reach them. It would be impossible to reach them. So it just shows like, again, sort of the same mindset of in the PT world, you have therapists who cares, you have therapists who don't care, you have surgeons who care, you also have surgeons who don't care.
Cassidy asked, I think, a fantastic question. What resources, whether books, courses, mentors, tools, have been the most instrumental in helping you reach the level of knowledge and expertise you have today?
Oh, I think mentorship has definitely been like the number one thing. Like when I first got to Healthy Baller, I was so raw. I was still under the 3x10 thing. Everything was 3x10, not really understand strength and conditioning principles. And thankfully enough, like our facility, we believe so much in mentoring that like Teddy, we met, I think, twice a week for like an hour each session. We just kept meeting and he just kept making me smarter essentially. And it just like you literally can't put a price on that. And that I learned more in the first 3 months at Healthy Baller than I did in 2 years at my previous 2 jobs, because somebody was actually sitting down and answering my questions and sitting down and teaching me, and it's so crazy that our field doesn't do this regularly, when it's just like, hey, you're a new grad, come work with us. Here's your 15 patients. See you never, And like I would be lucky to ask a question at my last job for like 2 seconds, because they had to see their patients. And one of the people that really, I guess, really got my brain churning for sports rehab was Gab, at my first job. But even then, like he was only there part-time because he was with DC United, a pro sports team he was with for a while. But he was the first person who really like, actually took time to answer my questions. And I was like, his thought process really just got things churning for me. And then from there, I also scheduled a mentorship time with our strength coaches. And like I was really slow my first year. Like I took a $40,000 pay cut my first year, because we don't make a salary at our current job. We make money off every patient. And I was a new person starting, and I had no name for myself, and I was slowly building a name for myself. So I would schedule times to just like, can I shadow your sessions? Can I learn? Like, why did you do this? Why did you do this? Like, what was your thought process of programming here? Like I learned as much as I could and was try to be a sponge as much as possible. And then like, if I saw them do an exercise, I would literally go walk 3 steps away and go try it over there, because that's how I learn, right? I need to see it, I need to do it, and go back and forth. And then ultimately, like finding people on social media who are great, who you think are reputable, research-based, and evidence-based, all that kind of stuff. Like look at what they're doing, and then maybe shoot them a DM and ask them questions. Like you'd be surprised about how often people are willing to answer questions.
Wesley,
mentoring
what's
is a big
your
thing.
handle? Just, I'm sure they'll want to know.
WesleyWang.dpt. Nice and easy.
And he does respond to DMs. It's education is one of his main tenets, so don't be shy. Feel free to reach out.
Yeah, but
all right, let's ask maybe 1 or 2 more, because it is getting late and these questions will go on forever because it's such an awesome topic. This one's a good one. What is the most significant difference in your rehab approach with ACL allografts versus quad and or patellar tendon grafts? That's a big question, obviously, but if you could distill it down to 1 or 2 things, maybe.
Yeah, quad grafts really struggle with end range knee flexion power. So like if you're going from knee flexion to extension, like which if in deeper knee flexion angles, they're much weaker, very similar to a certain extent for the hamstring graft. But it's just because when the quad is in a lengthened position, they really struggle with that force and power development. So like, again, it's being somewhat smart, I guess, sometimes figuring stuff out, but just like put them in a bunch of different positions where they're really on stretch. Small example is that when you're doing a knee extension, have them lean back a little bit. That's going to put that quad on a little bit more stretch. And there actually is research that supports that that's more advantageous for quad grafts. Also doing like a split squat with your ACL leg in the back. That is really hard for quad grafts, or Bulgarian split squat with the foot in back. They really struggle with that. So that's, I would say, probably the biggest one. And then for patella tendon grafts, it's basically managing your pain. Like, can you load knees over toes without pain? And that's where like a gradual and progressive approach really comes into play. But you have to be able to do that. Like, it's sort of a perfect balancing act that you're trying to play of like understanding like, hey, like for a step down, like I always start with the lateral step down with 4 inches with the handheld assist. Then we go to 6 inches and 8 inches, and then once you can do 8 inches body weight, then we're going to start introducing forward step downs, back down to 4 inches, and then working our way up, because forward step downs place a lot more stress on the patella tendon than a lateral step down does. And that's sort of understanding like the intent behind every single exercise, and ultimately understand like the tens of dozens of variations that you can do within an exercise of how to regress it and how to progress it. And I think that's the sort of the big spectrum of how it works for ACL rehab. But yeah, pain, anterior knee pain is the biggest thing that you want to manage for patella tendon grafts.
Incredible job, sir. Really cannot thank you enough, not only for your knowledge and expertise and willingness to share tonight, but I think more importantly for raising the bar for our profession. For all those who are younger clinicians, early professionals, you know, Wesley's not been out 20 years. He's a relatively recent addition to the field and is absolutely setting it on fire. So excited for the presentation. Thank you for everything. Please reach out to him over Instagram. I'll be sending out this recording so you can see it. And stay tuned for more content on residency hot topics. Wesley, thank you so much. Much appreciated, sir.
I appreciate you having me on. Thanks, Ben.